Thank you so much. What a treat to be here with all of you today. This is one of my favorite topics because it's a pain point. We just hate when we have a patient react to an injection where they're clearly uncomfortable during euthanasia. So it's a pain point for us. So it's important to talk about how to reduce that away during euthanasia because pain really has no place in that procedure. While Suzanne just went through my bio, I want to add a little bit of clarity with the credentials that you do see here behind my name, and also some timing of when I received these credentials. So I am a veterinarian. CHPV stands for Certified Hospice and Palliative Care Veterinarian. And that certification or program that I went through was back in 2016. And that was through the International Association for Animal Hospice and Palliative Care. So if you really like end of life work and you want to take, I think it's about 125-hour program to become certified like me, reach out to the IAA-HPC. CPEV stands for Certified Peaceful Euthanasia Veterinarian, and those credentials came through CADA, the Companion Animal Euthanasia Training Academy, of which I am the founder and director of education. And then DACAW stands for a diplomate in the American College of Animal Welfare, and I received that status last summer in 2024. And I did that because I wanted to learn about aspects of euthanasia and end-of-life support for a whole variety of different animal industries, including zoo medicine to marine mammal care, lab animal research, and then also be able to bring the knowledge that I have with companion animal euthanasia out to those other industries. So it was a 4-year journey and absolutely adored it. And so if you are interested in becoming boarded in animal welfare, for you veterinarians out there, feel free to reach out to me at any time. When we're trying to reduce pain, that is a big mission of Zomedica. This is why they invite me in to have this conversation. In particular, to help to enlighten you and build awareness to their Assisi loop and their Assisi products that I personally use regularly to try to reduce pain in my patients well in advance of euthanasia when possible. But just Zomedica has been a big champion of CADA for a long time, and certainly my teaching. So thank you again for inviting me in. We are going to start out with what caregivers, also known as owners, clients, pet parents, family, you're going to hear me use these terms interchangeably, what they consider painful and what might lead them to feel like pain led to a dysthanasia. Dysthanasia has been defined as a bad death experience. And then we're going to spend the majority of our time on pre-euthanasia sedation and anesthesia protocols, trying to reduce painful injections, and a bit of time on the euthanasia techniques themselves and making sure that those are not painful. And then what to do if pain does happen. So how will we address a dysthanasia situation to try to salvage that relationship with our client and, of course, kind of create a legacy with future patients so it never happens again. Why me to bring this information to you? I think we've painted a decent picture so far of how much time I've spent around euthanasia, but it's really been about a 19-year focus of my career. And these days, I spend a lot of my time writing and researching and teaching about euthanasia, but I still provide the service here in Northern Colorado. That's where I am today. And I love it. I love being able to work with families. And so I'm regularly honing my skills to try to decrease pain. And some of you might be looking for that perfect answer to always prevent pain, but darn it, sometimes no matter what we do, we get a reaction from our patient, and it is just part of the process. So what can we do from beginning to end to try to minimize that? That is what I still work on to this day with the families and patients that I help in my little euthanasia comfort center. If you're wondering what I'm doing in this bottom left picture, this is me researching the use of oral pentobarbital, the pure pentobarbital, Fatal Plus in particular, and injecting it into little cellulose capsules to then feed to aggressive dogs at an animal shelter in the hopes of understanding if that's a viable drug that we can use not only to impart anesthesia, but to actually achieve death. And so far, that's an ongoing study, but that's what that picture is, just showing that I am out there researching and trying to cut down on pain and anxiety, even for aggressive patients in animal shelters. If you haven't seen this before, this is CADA's 14 essential components of good euthanasia. There's 14 because there's 14 letters in these two words. I probably could come up with 30 to 40 different essential components, but we wanted to keep it simple. And you will notice here that one of them is to avoid pain and anxiety. And one of the ways we try to do that is to use pre-euthanasia sedation or anesthesia. And certainly through letter D, delivering proper technique. And allowing loved ones to be there, to witness, to be present through everything. And, really trying to sculpt this appointment in such a way that it's gentle for everyone. So this list, the idea is that before euthanasia, you are reflecting on it, thinking, are we ready to do these things? And then during, are we? And afterwards, did we? And if we find that we're regularly struggling with pain and causing distress in our patients, then there's an opportunity to make change. This article came out quite a few years ago in DBM 360, showing us how pet owners define a good death. And then afterwards, we did a study with veterinarians asking them what's important and tried to come up with a definition that aligns with both. These were over 2,000 pet owners that weighed in and helped us to get to this definition right here. The proper use of technique to end the life of an animal with minimal to no pain or anxiety. It's right there in the definition. And the first statement that I just made is quite academic. You will find that in the AVMA euthanasia guidelines and guidelines by groups like WASABA and AHA, just trying to keep things nice and smooth and gentle. But then we start to layer on some more details because we're taking into account the companion aspect of this. So human loved ones that are present. So best facilitated through the use of sedatives and anesthetics to allow our pet patient to be sleeping in those final moments. That allows the informed pet owner to remain present for the entirety of the procedure. Why that is important is because sometimes if we are worried about imparting pain, we might ask the owner or client not to be there in the room. But that's not necessarily the best approach. The best approach is to try to prevent pain in the first place, to allow them to be there. And if we really think pain is going to occur, then to at least inform the client about why that is and how we're doing everything in our ability to try to reduce it. But maybe it is a necessary because we have to release this animal from its body sooner than later. So pain might be a bit of that trade-off. Again, we're going to try to avoid it, but sometimes that is not always the case. The blessed sleep. So why are we using sedatives and anesthetics and risking potential pain from those injections into the muscle, into the sub-Q space with drugs like teletamine or ketamine, midazolam? Those are kind of the big offenders. But it's worthwhile because of the benefits that sleep provides, right? Sleeping in those final moments, closeness. Maybe we've got a cat in particular that's never liked to be cuddled, never was a snuggler, and now for the first time with sleep and just a few minutes before euthanasia takes place, the family can be close. That's a real plus. And maybe we've had a patient that's been so painful for the last couple of months, and now just a few moments of calmness and ease before we move forward with euthanasia. Really powerful. A one Stafford procedure, kind of with that chemical restraint, is nice. And if we have anesthetize our patients, then we have technique options that are increasing. That will become clear here in a moment. And I do think that sleep before death is a euphemism for death itself. And it can help those who are watching to come to terms with this new reality, knowing that in just a couple of minutes, they're going to see their pet going from breathing to quiet. With all energy being released, it's quite soothing that way. Now, I want to be really clear on what we're advocating for here. We are talking about providing sedation and anesthesia drugs to our patient before we do anything related to the actual euthanasia technique, such as shaving up for a catheter placement or, positioning the body in such a way, getting it ready for an intra-organ injection. We are providing sleep, and then we can decide what kind of technique we want to do. All right. Here are my protocols for canines, for dogs. I have a sedation protocol and I have an anesthesia protocol. My sedation protocol, those 3 drugs, dexmedetomidine, butorphanol, and ACE, are all going to be combined into one syringe and given, typically for me, sub-Q, because that's a pretty high dose of dexmedetomidine. So I typically give it sub-Q. As we know that muscular injections can hurt a little bit more, especially depending on where we're giving it and if it's a really tight muscle. But if I need to give something IM, we'll talk about where that is, but let me back up. Anesthesia, if I'm going to give anesthesia, I'm often going to give that intramuscular or maybe sub-Q. But within that cocktail, I've got teletamine, acepromazine, and dexmedetomidine. Okay, so those are my typical doses there, because sometimes I need my patient anesthetized. You are welcome to take a screenshot of this. Just include that CATO logo in the upper right corner. So let me just give a moment for that. And then I'm going to move on to my feline protocols. So this is what I use for cats. And you'll notice both of them are anesthetics or anesthesia protocols, because my preferred euthanasia technique in cats is intrarenal. I like to give pentobarbital into the kidney. Pentobarbital is still my most common euthanasia drug that I use, and I know I can give it into the kidney, so I need my patient anesthetized. The first one is teletamine, ACE, and butorphanol all mixed in. And then the second one shows alfaxalone, butorphanol, and acepromazine, again, all mixed in. And I give that one only IM because alfaxalone really is best IV or IM. I don't think I've ever given alfaxalone sub-Q, at least to a cat. Now, moving along to routes of administration, what's going to be the least painful? As a general rule, sub-Q is more comfortable than intramuscular. However, we have studies that show that deep epaxial muscle injections are shown to be less painful. So if you do have to give an injection into a muscle, or you're worried about scruffing, kind of what it shows here in this lower picture with the cat, maybe you're going for intramuscular injections there in the epaxial region. Intravenous is another way to get these drugs into the body, and best if we've already got a catheter placed. If we don't have a catheter placed, that's a lot of restraint to try to get in an IV injection, which can be painful with that needle going through the skin. It's painful if the drug extravasates outside of the vein and kind of blows right there. So I would personally prefer to go sub-Q or intramuscular with these drugs unless I've already got a catheter placed. Inhalation of gases is another possibility, not necessarily considered directly painful, but definitely aversive, depending on the type of gases that we are working with. So please consider that fact. And then we can also get a lot of these drugs in orally when they're actually ingested, swallowed down and absorbing across the stomach lining, or we can give drugs transmucosally. That might be kind of the future of pre-med sedatives and anesthetic administration, is trying to do more transmucosal, typically in the mouth. Transdermal, who knows? That might be a possibility in the future, but right now, a lot of the drugs that you might consider giving transdermal are not at a high enough concentration to elicit the type of depth of sleep that we are looking for. Rectal is another form of transmucosal, however, not typically done just because of the amount of handling that's required. Intranasal, again, things that can be done, but maybe still a little less common than what we are doing commonly. All right, moving on. Best practices for giving injections: just move slow, move calm, try to reduce stress around your patient. Always distract if you can, get them focused in on something else. I like to do a lot of desensitization where I'm rubbing the area where I'm going to inject. I do a lot of tenting of the skin, just a lot of massaging. And if you have a patient that is pretty wiggly, moving around, pretty active, sometimes we just have to get that drug in quick, so we can't go as slow as what we want, but that might be the lesser evil. So inject slowly unless you do have to go fast. Let's watch an injection, an intramuscular injection of a very thin cat that doesn't have much sub-Q space for me to work with. I'm also by myself. This is not a true scruff, but instead I'm just letting her know that I'm there. This is a teletamine injection in the thigh because I didn't have a lot of apaxial muscle to work with. I was concerned about hitting her spine. She's covered with mats. She's just very, very unkempt. So now I'm just going to support her with this teletamine protocol. So if you are thinking to yourself, wow, how did Dr. Cooney just give that IM injection of a teletamine drug that's got a low pH with zero response to the cat? Very tiny needle, relatively slow push. I had already desensitized and gotten her used to my touch there. She was curious to look around the room. I would have loved to have provided her with some foods and distraction. It just wasn't available for us at that moment. And now I'm starting to massage to help to work that drug in. Okay, so we'll talk more about that here in just a second. Here's a sub-Q injection of my own dog with a little photo bomber in the window there watching to see what's happening. That's my pug Darby. So here you see me just desensitizing, getting Eleanor ready for that injection. I'm tenting and then just slip that needle in right nice and simple. And then I continue to distract away from it. Get her thinking about something else and then pull that needle out. You know how to give injections. I'm just showing you how I do it. If you're curious what kind of foods tend to resonate as a good distraction, I love the churu paste that you can see this cat mowing on right here. But I also love cheeses. I used to use pill pockets all the time. Bacon is a favorite for just about every carnivore or omnivore out there. And then certainly favorite foods. Here's a bulldog in the bottom picture just loving on bananas. Nothing else matters but bananas. So go ahead and give an injection. So when you can distract with food, absolutely. Sometimes you can distract with other things that are around the room. Opening a door is a good distraction. Just, having something for them to look at and focus their energy on. Option for pre-visit pharmaceuticals. We love these and cannot overstate the importance of them if you are worried about a painful injection or high anxiety during the appointment. So if sleep is the desired effect, you can go really big with these doses. Here's a blog written in 2021 that's on the CADA website, cadainternational.com, which gives you different drugs for dogs and cats, the doses, as well as what we call the modified chill protocol. You're probably familiar with the chill protocol that was developed at Tufts with Dr. Alicia Karras and her team. We have bumped it up significantly with the doses and added in one of my favorite drugs, which is ditomidine, given transmucosally for dogs. Really, really useful. So you want to give these drugs well in advance. We're talking 2 to 3 hours ahead of time before the patient might be coming into your practice, or maybe you're going to the home. And again, go really big. Here's a dog named Lulu that came to my comfort center in Colorado. She was super anxious about everything. We knew that if I even got near her with a needle, she was going to react. So I went ahead and gave her ditomidine gel transmucosally, and that was her on the left before, and here she is about 5 minutes later, nice and relaxed, while the owner and I are still going through paperwork and talking through things, but we've already got our Lulu nice and comfortable. And we know that it's got some pain relieving properties to it, which is even better. So factors that may worsen an injection reaction. Patient temperament. How are they with handling in the first place? Do they get immediately suspicious when you approach to do anything? I have a pug, and when I lift her up, she says, "What's coming? What's gonna happen here?" And she might get herself already more tense. She's gonna, tighten those muscles, can actually worsen a reaction. How are they with their familiarity with injections? Maybe they're like, no big deal, go for it, or they hate them all the way around. Injecting a sore area, we definitely want to avoid that. So if we know that they're tender somewhere, we should not be injecting that area. And I promise you, your clients are grateful for that. Maybe we have a patient that has allodynia or hyperalgesia. Allodynia is a sensitivity to something that should not be painful. If you watch my video here of me, you're going to see me just kind of touching my face. This should not be painful, but those with allodynia and hypersensitivity might find this painful. Hyperalgesia is you're doing something to the body that is painful, but it's extra painful because of their extra sensitivity. So I'm just going to keep my video here. Me pulling out some hair, yep, that's going to be painful, but it's going to be extra painful if I have hyperalgesia. One of the ways that I work with my end-of-life patients with hospice and palliative care is to get them using a device like a CC, whether or not it's a loop or a lounge pad. Just regularly having them treating that pain, cutting down on inflammation, hopefully helps to cut down on pain during euthanasia. So please make sure that you are providing good analgesia to your patients well in advance of euthanasia if you have that opportunity, because hopefully they will be more comfortable during the procedure when the time comes. Okay. And then lastly, rubbing the injection post-injection can worsen an injection reaction. If you have just given, like you saw in that cat video, if you've given teletamine, which is a low pH drug, into the muscle and you immediately start rubbing it in, that might be painful because you've just damaged tissue and infused in a low pH drug, and now you're massaging. They might not have reacted to the injection, but now they're reacting to the massage. So wait just 30 seconds to a minute. Put your hand over that injection area, maybe move around just a little bit, see if they respond. And if they don't, then you can go ahead and massage a little bit more. Preparing the client for giving an injection. Maybe ask, how has he been with injections in the past? And then they can say, usually does pretty well or hates them. What my least favorite situation is when they say, oh, he always does wonderful with injections. He's never growled. He's never expressed any sort of, real pain with an injection. So then my pressure goes up to make sure that I don't cause pain for the very first time in the last moments of life. You should be asking, is he sensitive anywhere that I should know about? Because then we want to avoid that spot. There is a gentleman that reached out to me many years ago as a pet owner that I had nothing to do with his pet's euthanasia, but he believes that his cat experienced a dyskinesia. And he says that all that really needed to be done was for the veterinary team to ask, where is his cat sensitive, rather than defaulting and giving the injection right there, which is what happened. And the cat had a violent reaction. So his message that I am now carrying through to you is, please ask your clients where their pet might be sensitive so you can avoid that area. And maybe be avoiding injections altogether and moving to oral administration if that's the best approach. If you do have to give an injection and it maybe has a little heat to it, such as teletamine, ketamine, or midazolam with their low pH that is known to sting, you might just preface with a little heat to it. If he talks to me, I understand, but we all agree this is the best way to help him to relax into very deep sleep so we can then help to release him more gently with his body or from his body. If he does notice, he will welcome sleep very quickly. So I now talk to my clients quite a bit more about options with the pre-meds. And if I'm concerned and they're concerned about a painful injection, if we have the option to do oral drugs, we discuss it. And if we decide that the patient hates their mouth being touched, they're going to dislike that even more than an injection, then we will go ahead and give that into the muscle or underneath the skin. But if he notices it's okay, he's going to welcome sleep very quickly and will still be as gentle as we can. So these are some of the drugs that we're talking about. And I'm going to leave this screen up for a second while I close my shade just a little bit, because the sun is peeking out. There we go. So Sedative and anesthetic drugs. We have sedatives listed first: alpha-2 agonists, opioids, phenothiazines, and benzodiazepines. The benzodiazepine midazolam is known to have some sting to it that we would often be using IM or sub-Q, low pH. Dissociatives like ketamine and taletamine are culprits, low pH. And then we might be working with, propofol, which also burns if it gets outside of the vein, but typically we're using that with IV catheters that are placed, so drugs should not be leaking out. The neurosteroid alfaxalone is really quite benign. And so if you've been considering using that as a pre-euthanasia med for cats or small mammals, even reptiles and birds can have it, then alfaxalone might be a good fit for you. So let's talk about what it means to remove the dissociative sting, ketamine and taletamine, low pH. Here is a little chart that I compiled when I was looking at pH testing strips of tilazol in particular, mixed in with other agents. So tilazol was saline. Saline has a pH of 7, but when you mix it with tilazol, it's still less than 3, or right around that 3 pH. Plasmolite with tilazol, maybe a little bit higher, maybe 3 to 4 on that scale. Buffered lidocaine didn't do much at all. B12 didn't do much at all. Still had a low pH with tilazol. So if you're wondering if B12 makes a big difference and cuts down on pain, if it does, I don't know why. Maybe it's neutralizing an alcohol or doing something, or simply the dilution is solution to pollution idea. But B12 has a low pH at 3.9, and in tilazol was still pretty low. So I don't know why it works and why some people swear by it. Bicarb had the best results. So just putting in a drop of liquid bicarb right into your protocol, your combined drug syringes right before injection, that actually raised the pH up the highest. So that might be an opportunity for you. pH buffering solution didn't do much, and then acepromazine mixed in also didn't do much. So if we are trying to put in other agents or something simple like saline or plasmolite, it might again be that dilution is the solution to pollution, and they're just not noticing it quite so much. But liquid bicarb might be one of the best answers. And this is where you can find information on some protocols to support this. So we have one called Reducing Pain During Pre-Euthanasia Sedative Injections from a couple of years ago. And in there, I list 4 different protocols from veterinarians who swear by their approach. One of them is infusing in a lot of saline to the area, almost like sub-Q fluids. So infusing in saline first, followed by taletamine protocol, followed by more saline. And this veterinarian says absolutely no response whatsoever. But you have to have the right kind of patient to be tolerant of a lot of sub-Q fluids, hopefully while they're eating churu or something else, and not noticing that. So anyway, lots of good tips in there for you. But one of them that's listed in that blog is this idea of just doing what's called a 2-step protocol. So if you're really worried about ketamine or taletamine stinging, then maybe what we're doing is, rather than mixing it into a syringe and giving it in just one fell swoop, we're doing a 2-step protocol. Step 1, we're giving some sub-Q butorphanol and acepromazine. I hear sometimes from people that say that acepromazine stings. I just don't see the reaction the way that other people are seeing the reaction. I'm seeing a lot of comfort. So butorphanol and ACE given sub-Q ahead of time. Then wait 5 to 10 minutes, allow your patient to get more comfortable. And depending on their depth of sleep, you might be able to place an IV catheter and administer propofol to induce actual anesthesia if that's what you want, and then followed by pentobarbital. Or your step 2 is maybe an IM injection of ketamine or taletamine with more acepromazine and more butorphanol, or maybe you're mixing in some dexmedetomidine. So rather than giving something that burns first, you're giving something a bit more benign, and then you give a second injection with something that's got more heat to it if you even need it. Oh, I forgot that I put in the chill protocol, the modified chill protocol that Kata uses. So the night before, we're using gabapentin and melatonin. 2 hours before the appointment, we're doing a higher dose of gabapentin and we're using melatonin again. Then we're going nice and high with ace-promazine about 30 minutes before the appointment. Transmucosal, okay, transmucosal for good absorption. And then what we have added on is we are now using detomidine gel before the car ride or maybe before your car ride to get to the home for euthanasia. So you are sending home these medicines, these drugs for the owner to give, including detomidine gel. So if you're wondering what's detomidine gel, the brand name that's out there is dermosedan gel from Zoetis. You, I believe, have detomidine gel up in Canada, in case I've got any Canadians with me today. And you can also just give dexmedetomidine, medetomidine, detomidine liquid transmucosal if you don't have that gel. It just induces deeper sleep. And I love it for dogs that are aggressive, highly fearful, might lash out during the euthanasia appointment. This dog in this image was a dog that I met the day before coming to me for aggression and behavioral euthanasia. And this dog wanted nothing to do with me, was barking very, very aggressively. And family had become afraid of the dog, and it was now an unfortunate threat. So we went ahead and gave all of these drugs, and this is how the dog came to my comfort center the next day, soundly sleeping, but not anesthetized. So when the dog was still in the vehicle, I gave an IM injection of my teledimine protocol, waited for the dog to anesthetize, and then brought it into my comfort room. So I did a two-step protocol. The first ones were all oral, and then the second one was an IM injection of my anesthetic drugs. Very good. That is a whirlwind run through of the pre-meds that we are often using and we're encouraging you to use. Next, we are going to move into actual euthanasia techniques themselves and making sure these are not painful. I look at a dog like this, which for me, many, many years, the Pekingese was kind of my nemesis because they're like a living Muppet. They've got so much fur. They've got short little noses, little legs. Often they have heart disease, which can make euthanasia challenging, but it's just a lot to work with. So I often say, what's the challenge with a dog like this? And the answer is dog. But there are a lot of other situations that can make you have concerns about how the procedure is going to go and have worry about pain. So let's just talk through what would be potentially the right techniques for your patients to keep them very comfortable. We have a lot of different ways to get pentobarbital into the body. Intravenous is the most common. And the doses that I'm showing you here are appropriate for the United States and many other countries. However, some countries have higher doses. So please keep that in mind depending on where you practice. 1 ml might look on the low side depending on what you have your norms. This is also based on 390 mg per ml pentobarbital concentration. Most common way for many of our species is to do intravenous injections. But we know that we can give pentobarbital in other areas of high perfusion, such as the heart, the liver, the kidney. And then we can also give drug into the abdominal space, the peritoneal space, in some of our patients. Peritoneal is typically done in animal shelters or for exotics in private practice. But we do recognize that putting euthanasia solution into the abdomen does have the potential for pain when they are awake. That said, in private practice, we don't tend to do a lot of intraperitoneal injections because maybe we've got better support and skill to do intravenous injections, or we are anesthetizing our patients, and then we can give the drug into an organ. Why do we do this? We do this because sometimes the vein and the abdomen just aren't going to be, going to be efficient, aren't going to be practical. And we're just trying to get the drug into an area of good blood flow so that the pentobarbital can get up to the brain. That is where it works. Regardless of where we put it into the body, we are overdosing the brain and the brainstem in particular. So if you choose to use an organ like what's shown here, your patient needs to be anesthetized. Real quick, let's just talk about intravenous injections and trying to set yourself up for success and try to minimize pain. Well, if you've got a heavily sedated animal or an anesthetized animal, they will not notice when you are going to place an IV catheter. So if the vein blows, no big deal. You got to try it a couple times on the same leg, no big deal. They're sleeping and they are unaware. If you want greater success, these are the tips for you here. When it comes to actual pentobarbital administration for your through your intravenous injection, these last two bullets are important. You inject fast with awake animals, and you inject slow for heavily sedated patients. I don't have more time to talk about that than what I just stated, so if you want to know more, we encourage you to keep learning with CADA. Now we are going to move into intra-organ injections, but we need to make sure that our patient is properly anesthetized and unconscious, and they're not going to feel any pain. So these are some of the things that you can do to make sure that your patient is not reacting. So you can touch the face, you can do a palpebral check, making sure there's no blinking. Even though some depths of anesthesia, you can still see blink, but your patient is unaware. So you can feel the abdomen, see if there's any muscle tensing, and see if there's resistance. This is one of my favorites. You can see my little fingernails there really grinding into the flesh in between the toes, but it kind of looks like I'm massaging. It doesn't, if the family is watching, that doesn't necessarily look too offensive, but we are trying to elicit pain. We're checking for reflexes. And when we see none and we know that our patient is ready, now we can move forward with intracardiac injections. Here are some videos of intracardiac injections just showing what this can look like. Remember, the patient feels nothing. Now, intracardiac injections have historically been something that we worry about with clients watching. They're seeing blood. They think that we're hurting the heart in some way. So we need to make sure that we are conveying confidence with this and doing the technique properly so that the client knows that their pet feels nothing and that you feel confident that your patient feels nothing. Okay, so there's lots of different ways to teach intracardiac injections, but just showing you that it absolutely can be done with no pain with your loved ones, your clients in the room. Moving along to intrahepatic injections. I think this is going to show a little video down below. Intrahepatic injections, again, anesthetized patients. We're just trying to bathe the liver in euthanasia solution. In the bottom video, we see a dog that is anesthetized with my teledimine protocol. I'm going to reach in with an 18 gauge needle, about 1.5 inches long, and I'm just going to infuse that pentobarbital around the liver. I can redirect a little bit, infuse it in different areas. Patient feels nothing. I'm just hoping that I've given the drug in a way that the medicine can get up to the brain quickly for effect. Now, I put better for smaller pets because that's a comfort level for me that I know that if I miss the liver, I might be going intraperitoneal, which can take a long time. But a lot of practitioners love to do intrahepatic injections on dogs, even upwards of 200 pounds, right? As long as you got enough drug and you got your patient anesthetized, you may do that. For intrarenal injections, here is that cat that we saw me give that intramuscular teledimine protocol to earlier. Now she's anesthetized. Takes me just a moment to find that right kidney, so I'm not that left kidney, so I'm not accidentally injecting a mat. Insert in an 18 gauge 1-inch needle with then pentobarbital being infused in. Death comes very rapidly. This is an elegant technique. She's completely unaware. How nice that the family could have the cat right up here, cradled in their arms. You can do this for rabbits, for guinea pigs, for small dogs where you can feel the kidney. If you can feel the kidney, you can do this technique. So moving along, what happens if you do have a dyskinesia? What if your patient cried out in pain, your client is upset? Dyskinesia is kind of a matter of perception. What could be a dyskinesia to one person may not be to another. You might have thought that things actually went quite well, but your client is upset. Our recommendation is to call within 24 hours, have the most informed person that knows what happened during the procedure, have them reach out and talk to the family, and make sure to provide time to talk about what actually took place. Because someone like your client might think that their pet was painful, but it actually wasn't. Maybe it was just an involuntary response to the drugs afterwards, or like a pentobarbital administration where there's some euphoria that the patient experiences, but it's not really pain. We did that study asking pet owners what are they expecting during euthanasia? How do they define a good death? What they are most afraid of is seizures. So if you think that seizures are possible, make sure to talk about it, because to your client, it looks like really physical pain. So make sure that they are aware that seizures, the patient is unaware of what's happening, they're okay. You can actually wait for seizures to dissipate before you proceed. Pain came in number 2 for what they want to avoid. Create a positive from a dyskinesia. If you've got an upset client, I promise you the most important thing to them is that you are acknowledging how things went and that you're going to try to create a legacy from it to help, future animals avoid a similar experience. That is what they want. They want open communication and to know that something positive will come from it. And then make sure to talk about things with the team, because if you yourself felt that it was bad and you're hurting because of it, then you want to make sure to talk to others and try to avoid it happening again. And please consider calling in reinforcements. If you are worried about pain and maybe you're not the right one to support this patient and talk to the client about what's happening, maybe you leverage others out there that are really good with this type of patient, that is good with that situation, whether or not it's in the hospital or in the home. So be open to calling in reinforcements rather than putting your patient through unnecessary pain. In summary, avoid it from the start and be very thoughtful. Those low pH drugs like ketamine, toluidamine, and midazolam do have a low pH and they can hurt. So try to use that dilution as a solution to pollution. Consider a 2-step protocol. And hey, if you don't have to use a low pH drug, especially as your first go-to, yeah, lean on something else. If you are doing intra-organ injections, this is an important one and I didn't mention it yet. If you are doing an intra-organ injection for an anesthetized patient, and you're using pentobarbital or some of the other drugs that are out there can be given intra-organ, it's just not as common. Inject slowly to start, rather than just blasting in pentobarbital into the liver, for example. Start slowly, 0.1 mil, 0.2 mil, 0.3, and test to make sure that your patient is comfortable. Because if you blast in a high pH drug like pentobarbital, which is more caustic and alkaline, they can react to that. So if you blast it in and they're not as unconscious as you think they are, maybe you assessed everything, but now you've blasted it in and you see squirming from your patient, no good, no good. So start slowly and just kind of test 0.1 mil, 0.2, and see how they're doing. And then you can start to infuse in a little bit faster. As we just said, create a legacy to do better if pain does occur and apologize if warranted. I want to make mention of another Zomedica product, which is their Vet Guardian device, which is a monitor that is used typically in emergency settings or for hospitalized patients, that is able to monitor temp and pulse and respiration. Really cool device. The reason I wanted to make sure to mention this is because a lot of times we are doing euthanasia in emergency settings. And the more we know about the health of our patient before we euthanize, the better. And can also be a little bit more proactive in choosing euthanasia before our patient gets critical and we just weren't aware of how critical they were, unless a device like Vet Guardian can tell us that. So I really like this device. I also think it's interesting, and I'm going to be talking to Zomedica about maybe using it for euthanasia research, because I do think there's some opportunities there for such a thing. All right, and just lastly, remember to call in the experts if you need. If you are not the right person to be euthanizing, you're worried, you just don't feel like you've got the skills for it, then be bold and do such a thing to make sure that your patient has a peaceful passing. If you are interested in learning more about euthanasia and a whole host of topics, and you want to become a CPEV like me, or for you technicians and vet assistants and other support personnel want to become certified peaceful euthanasia professionals, we have 10 hours of RACE approved CE online for you to take at your pace. And we will teach you so much more about all of these techniques and these approaches, including business tips and communication. CADA is an educational division of Lap of Love, who we have partnered with here to provide you some veterinary resources. So please consider scanning this and or going to the URL there and joining or signing up for our newsletters. We'll tell you when webinars like this are taking place and when we're going to be at particular events so you can join us. And also when we have our newsletters and our blogs. The blogs are very popular. I would encourage you to go to cadainternational.com at any point to check out those blogs. They're a great resource. Speaking of more resources, we have a couple events that are coming up that Zomedica wanted us to make sure to share with you today. We have a euthanasia techniques workshop, which will be at the New York Vet Show on November 6th. I will be teaching how to cut down on pain during injections and during euthanasia. So that's a popular one. And then if you want to know more about communication, we have a 4-hour communication workshop, also RACE approved for any member of the veterinary team, that is coming up in December.